Hello, I'm Mark Rickenbart, and I'm a GP, a general practitioner near Southampton. And we're talking today about careers in general practice. I'm a visiting professor of healthcare at Winchester University and a lead for continuity of care at the College of GPs. You can see my website there and email if you want to get in contact. And on this page, you'll see the two surgeries that I've been working at as a partner, as a GP partner. St Francis Surgery in Chandler's is the lower one, and the earlier, what is now a branch surgery, is Park Surgery in Chandler's winter and summer. Going to talk about the journey to becoming a general practitioner, general practice itself. I'm going to illustrate some common medical problems and ask you a few diagnoses. And then we're going to go on to talk about portfolio careers and some interview tips. So the first thing is, do you want to do medicine? And that's the question that takes you in normally. And then the second question you'll come across is which specialty? And my suggestion is that you can combine medicine with other things as well as medicine alone. In fact, it's probably better to have a portfolio of things that you do so that you balance them up. So the decision for medicine for me might be coloured a bit by the fact that my father was a general practitioner. And sadly, he died when I was 7 years old of a brain tumour. And that meant that in one way I had him up on a pedestal and wanted to follow. And on the other way, I probably wanted to do better and better in inverted commas and be a consultant in a hospital setting. This odd belief is something that's fostered in medical school that somehow one job is better than another job. It's what suits you most. So I decided I wanted to do medicine, and I got sufficient A levels, an A, B, and C at that point, and went to the London Hospital in Whitechapel. And then I had this decision about which specialty after I qualified as a doctor. Um, and initially, I looked at the hospital specialties. Consultant in cardiology was one that appealed, or eye care. And then I realized that actually I wanted to look at the whole body. I was just looking at a little bit, and it was becoming a bit repetitive, saying the same things every time. So I could be a world expert in a very small area, or I could be a generalist and deal with anything that I wanted to and do a whole body, be holistic in approach, and look after the whole patient. So that's why I became a GP and I set up my own general practice rotation. So some medical students at the top, at that time wearing white coats outside the A&E department. I then worked in Western Australia after completing most of my training, where I was doing cardiology and A&E for a 9 month period with my 3 month old son and my wife, Louise, who's a physiotherapist. And then in 1991, I was outside, or we were parked beside this frozen lake in Chandler's Ford. It wasn't frozen then, but having an interview for my general practice post. The journey on the way, the 5 years in medical school, I did a BSc, so I took an extra year looking at pharmacology. It's now 2 years in foundation. At the time, I did house posts and an SHO, senior house officer posts. And I did an extra couple of years as specialty training. I got my MRCP. And then, so that's an optional thing. And then you'd have 18 months within the general practice setting, normally a total of 3 years for GP training, including the full-time GP post. And then after you qualify, you might spend some time as a locum doing posts here and there. I spent a year in that situation. It was really good experience seeing different practices. And then you might get a salaried post where you're employed. or become a GP partner where you're responsible for running the practice and the business. The first clinical case for you is a name for this particular condition. And give me a minute when I get back to where I was. Um, and this is a young person. From the appearance, the eye itself is not particularly red, and the area around the eye socket is not particularly red or inflamed. It seems to be quite localized. So I'll let you think about that when I say that this was the general practice that I joined. Not actually the building I went into as shown earlier, but the original building that was in place in 1897, some 125-ish years ago, when the practice was established. There you can see a picture of the road. Park Surgery was in Park Road at that time. And you can see the doorbell, which is still there now with its day and night call. So in the daytime, the bell would ring downstairs, and at night time, the bell would ring upstairs to wake them and get them out of bed so they could get onto their horse and go to the place they were going to. Excuse me just a second. I'm in trouble getting this one. So coming back to the eye problem, which I hope you're all thinking about and making a note on, I hope you were right. It's a chalazion, which is a swelling in the upper eyelid. In this case, it can be lower eyelid. Different from a stye, which is on the edge. A chalazion tends to be within the eyelid. There's a plate of cartilage sitting in the upper eyelid, and the chalazion can either be in front of it or behind it. And it's useful to know which because you can make the cut and try and avoid going through the plate to drain it out if you wanted to. Stye more on the edge, and most of the treatments are local treatments. I still do what my mother did, which is suggest wrapping cloth around a spoon, dipping it in boiled water, and letting the steam come up and open up the pores. There's no clear-cut evidence for this, but it's a practical way of giving advice. Hot flannel might be equally good. Um, it's mainly time, and time is the GP's friend, because with time, most things resolve. If it went on and on, you could offer to cut it, and I have a Calasian clamp which holds it in place that I use at my surgery if we need to do that. But in almost all cases, it settles. Warning signs, the serious, what is it? Are redness and swelling around the eye or red eye, which suggests a different diagnosis. You don't get red eye or swelling around in a chalazion. And when you see a condition, you can see a copy of my website here. You think about what's the serious thing I need to exclude? The heart attack, the pulmonary embolus, the stroke. And what's the cause? You may not always be clear about the cause, but what you can do is decide how to manage it and use time and review the patient. So for me, general practice is like a corridor of consultations. Um, this could be doctor's waiting area or doctor's corridor. But from my point of view, I'm thinking of it as a door or cupboard door that I open and look inside to see the patient's issues and try and help them organize the shelves in their cupboard of their life and trying to help them get things so they can move forward. And I might be making a range of different suggestions. Often a patient will bring two or three things they want to talk about with me, and I will have two or three things that I know from the records I need to talk about with them, like their blood pressure or other things. So a good day for me is when I go down this corridor of consultations and I open the door, help the patient, close the door and move on to the next patient. And I feel the door is firmly closed. I get to the end of the consultations, usually about 12 nowadays in my surgery. It used to be 7 to 5 minute appointments, it's now nearer 15 to 20. And a good day is when I get to the end of this corridor and I feel all the doors are closed and I'm off home. A not so good day is when the doors are bulging a bit, things aren't quite sorted. I need to go back and think about the patient and go through their records a bit more. So the next clinical case, what is this condition? And for a bonus point, you could say what might be associated with it. And you'll see, and how you describe things is important. Pink, raised, dry, slightly scaling rash, and the location on the outer elbow is important. On the fingers, we've got a similar rash. There's also something happened to the nails. They've got thicker, more opaque. And if you looked carefully, you might see little pits in them, like someone had been sticking a pin into them. While you're thinking about that, I'm going to tell you about general practice a bit more and say it is exciting. You never quite know what's going to come through the door. And when I started in general practice, I'd be having strokes and heart attacks arriving on the doorstep that I'd be sorting out with intravenous drugs. Nowadays, the ambulance picks them up and quite rightly takes them to hospital where they can have thrombolysis to remove the clots from the blood vessel system affecting the heart or the brain. Um, but you never quite know what's coming through the door, so you've got that variety as well as the excitement. Yes, it is pressurized. I talked about 5 minute appointments. I started with 19 patients in a surgery when I began. So there are pressures. Um, but it's a great pleasure. And you have an emotional ups and downs with your patients. And of course, if your patients come in happy and thankful and appreciate what you've done, it's fantastic. But you cue into your emotions. If you feel a bit low, is it possible the patient's feeling low in front of you? If you feel slightly angry with them, is it possible they're angry? And you can use it as a cue and just say, I sense you might be a bit angry, or I sense you might be a bit low. But you will have that up and down of emotion as you go through your surgery. And sometimes you have to sit back, to have a cuppa, and recharge and refocus. And it is an art. It's not all scientific and clear-cut information. There is uncertainty in what you're doing, and you're matching it to the individual patient to make it as good as you can for them and tailored to their particular medical problems and social setting. So you have to be good at the uncertainty and using the basic principles of um, uh, watching and waiting. So come back to this one, and as you see, it is psoriasis. Um, and the rash here is fairly typical for psoriasis, which is normally on the elbows, on the knees, around the back of the ears. And it does cause nail changes with pitting, little pin pricks in the nails, not in everybody, but in some people. And the conditions associated with is arthropathy, painful joints. And you can treat psoriasis with light therapy, with topical creams that modify the condition. And it can be quite distressing for individuals. So it's an important condition to discuss and help with. So general practice itself, as I've said already, is an NHS franchise. It's a small business within the NHS as a whole. It sits within primary care, which includes health visitors, district nurses, pharmacy, and the wider community, which includes the voluntary sector. There might be somebody there giving advice on, say, the psoriasis and other skin conditions. And you've got the social sector, social care sector, and secondary care in the hospital that you're all working with. Next clinical condition, I'm going to give you a couple here now. What is this condition? And you might be able to name the test. And as I've said already, pop it in the chat box. Um, and this particular rash, it doesn't seem to be disappearing when you press glass against it. Now what you're effectively doing is stretching the blood vessels there. You can just stretch it with your finger to see. And if it's an area of inflammation, the blood vessel will disappear and you will lose that pinkness there. So it seems to be a bit more than inflammation. Perhaps the blood is leaking out of the vessel here, like a purpura. And what's happened here? You can see this eye is a bit more inflamed and red. And there's a brownish dot there with a white surround. Um, perhaps something sitting there, perhaps inflammation around it. So back to the rash. And in this case, it is meningitis. It's a purpuric rash. It doesn't blanch. And if you see something like this, always think meningitis, particularly in a young person at university, and you get help as soon as you can. This is an emergency to get antibiotics in and cure the condition, hopefully. Um, People may be unwell with it, but even if they're not, you need to act. Of course, as a GP, people will come in and say, I've got this rash. Is it meningitis, doctor? And the benefit I have is they walk in well and the rash has been there a few days. It's a recent onset, surprisingly quick change with symptoms. And what have we got here? Well, this is a foreign body, um, and it is sitting on the surface of the eye. And if you don't remove it, it can cause problems over time, possibly with opacity generally and infection and blindness. You can remove it in general practice. Most GPs don't, but I do. I just use the end of a needle, and it's a little ball of iron filing usually. This person may well be someone who does use machinery at work, particularly filing of iron and metal. Um, and once you've removed it, it heals up very well on its own. You can look for foreign bodies by lifting up the eyelid. You can just press on the upper eyelid, hold the lashes, lift it up, and you can see if there's anything on the underneath of the upper eyelid that might be scratching the eye. All these things you could be doing in general practice. I've given you pictures, but it's not just recognition. It's about recognizing patterns, making diagnosis, and option management of care. I'm going to mention continuity of care because I think that's very important. Seeing the same person over time as a doctor means that you are improving their care, because if you have continuity and seeing the same doctor, it reduces the chance of you dying. After 15 years, your chance of dying is reduced by 25%. You have less chance of going into hospital or needing urgent care, and you will be more satisfied as a patient and as a doctor, and you're saving resources and you're reducing your workload. And as a GP, I have continuity from birth through periods of difficulty and distress to end of life. And I have patients come in thanking me for when they looked after their children, and their children coming in and thanking me for when I looked after their parents. I mentioned a portfolio of career. Well, general practice has lots of things you can do alongside it. Um, and I had a couple of days doing research at time. I was always doing some teaching throughout my day and in teaching sessions. I worked with a patient participation group and did health walks, which is a national process that we do. I worked in the Olympics 2012 as a pitchside doctor on the hockey. I got COVID. I was one of the first GPs to have COVID. Um, but that led me to be able to describe COVID on the internet and talk about things like lying on your front to reduce cough. And it led to me collating funds for oximeters or oxygen meters to monitor the impact of COVID. So you could be a GP with an extended role. You could be exploring your own interests alongside your general practice, which is very much one session in a day or two sessions in a day, so you can work around it. There's also a book here called Healthcare Heroes. I did a bit of writing and poetry about the experience of being a patient in hospital. You'll see on the drip bag the words GIN, gin, upside down. I hasten to add it was not a medical treatment. It was just there for fun. So if you're going to do medicine, think about your values. Why do you want to do it? What are your beliefs? What's underpinning it for you? And often it's about meeting people, learning about people, helping people. But think carefully if you want to earn money, for example, because it's not a high earning situation. And why medicine in particular, you might have to think about. And when it comes to interviews, think about what is different about you. In my case, I did a bit of rollerblading between surgeries. Could say that was something different to talk about. Um, and think about what you want to say at interview because you can steer things around. But it helps if you say the things on your personal statement that are true, because if you don't, you might get asked difficult questions. Um, I can remember being asked about birds of prey. I knew about birds of prey, but I just clammed up at one of the interviews. So prepare what questions they might ask you and just something you might reply with. Doesn't have to be the correct answer. They're just looking for you to talk. And one of the ways you can help yourself talk is to think about a perspective sieve. If you're asked a question, think about it from different points of view. At the top left, you could think about yourself, how it affects you. Your parents, perhaps, your loved ones, um, how it might affect the GP in the surgery in the GP question, but it might be the person at work if you're doing an interview for something else. How it affects the team at that work setting, how it might affect the clients in your business or work setting or patients for a GP, how it might affect the other parts of the system, as in secondary care, what the government would think about it. What's the world impact? COVID would be an example. And if it was in the universe, what would be the importance here? So it gives you a way of discussing things. And my last player proposal here is or question to you is, what's this rash? Uh, this looks like it might be a man's leg. It looks like it's the groin area. And this is quite an itchy rash. And when you look at it, it's got a slightly increased area at the edge. So a demarcation, pink raised demarcation. Slightly scaly sometimes, you can see that. And you'll find on the history it's been spreading slowly over several months. If it's come on in one day, it's an infection, and you need to be more careful about monitoring it. If it's come on over a few months, you've got time. Skin rashes are usually bacterial infections or viral infections, or in this case, fungal infections. One called tinea crura. Crura means body, tinea is the type of infection, also commonly known as ringworm. And if you put cream on, Canesten cream, which you can get from the chemist, is really good, 3 times a day for at least 3 weeks until the rash is gone. Carry on as long as you need. And if it comes back, just put the same stuff back on. So there you are, a few things about general practice. I've come to the questions section. There's my website and email if you want. And I'll let you talk about it now. Thank you.